Children's Hospital in Cincinnati, Ohio. And Dr. Steiner recently completed his PGY2 in solid organ transplantation at the University of Chicago and will soon be joining the team at University of Illinois, Chicago as an abdominal transplant clinical pharmacist. In a moment, I will turn it over to Dr. ISHLT to begin the presentation, but first, a few just quick notes and housekeeping. So for those in the audience, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen if you're not familiar. If at any point during the presentation you have a question for our speakers, please submit your question by using the chat functionality at the bottom of the screen. Please send your questions directly to the moderator, me, of today's webinar to minimize possible interruptions. And we will take questions at the end of the presentation. And today's webinar will be recorded and posted to our ACCP Transplant YouTube channel. If you experience any technical difficulties during the webinar that are not fixed by logging out, please make sure that the moderator is aware through the chat functionality. So without further ado, today I will turn it over to Dr. ISHLT to take it away.
All right, can everyone see my slides?
Yes.
Perfect. All right, so hello everyone, and thank you so much, Rachel, for that introduction. As mentioned, my name is Stephanie ISHLT, and I am a pharmacy clinical specialist in lung transplant at Cincinnati Children's Hospital Medical Center. And I will be focusing my portion of today's presentation on some of the lung transplant content presented this past spring at ISHLT. So the objectives of this presentation will be as follows. So we will briefly review the current definition and diagnosis of chronic lung allograft dysfunction, otherwise known as CLAD, discuss updated literature on the management of CLAD risk factors, identify prophylactic treatment options for CLAD, and describe potential pathophysiologic mechanisms, biomarkers, and novel therapeutic approaches through a patient case. So probably the most difficult component of assembling this presentation really came down to deciding exactly how to pare down all of the great information presented at the meeting. However, I ultimately decided to land on a CLAD theme presentation because it is truly quite astonishing to me how far we have come in the field of thoracic organ transplantation, but yet how CLAD still remains the major barrier to long-term survival following lung transplantation. So because of that, this area of practice has been and continues to become a huge area for research and development, thus making it a pretty hot topic at the annual meeting. So before diving into the actual meeting content, I thought it would be beneficial to briefly review the current definition and diagnostic process. So CLAD is defined as a persistent decline in FEV1 of at least 20% of baseline value, which is sustained for generally about 3 months. It is a diagnosis of exclusion, meaning that other causes of declining spirometry have been ruled out. But once that diagnosis is made, a phenotype will need to be further defined, which is an important prognostic measure. So bronchiolitis obliterans syndrome, or BOS, is going to be our most common phenotype in comparison to RAS, or restrictive allograft syndrome, or even those patients who develop a mixed picture. So briefly, BOS is going to be our obstructive disease process, and how that is diagnosed is not only that decline in pulmonary function that we see through spirometry, but we will appreciate air trapping on high-resolution CT imaging of the chest and notable obliterative bronchiolitis on pathology. So there have been numerous risk factors for the development of CLAD identified. Some most notably include cold ischemia time, which leads to primary graft dysfunction, rejection, including both acute cellular rejection as well as antibody-mediated rejection, GERD, some surgical-related complications, a variety of infectious processes, as well as aspiration. So I will start us off by first discussing cold ischemia time and primary graft dysfunction. So ex vivo lung perfusion, or EVLP, is a relatively new and upcoming technique that is known to perfuse, ventilate, and monitor donor lungs prior to transplantation, which is helping to eliminate this cold ischemia time and subsequent primary graft dysfunction, and is allowing increased usage of expanded criteria donor lungs, including donation after cardiac death. So the purpose of this retrospective multi-center international study presented by Dr. Casham out of Temple University and colleagues was to compare lung transplant outcomes by EVLP utilization stratified by DCD or DBD recipients, looking at both total ischemic time as well as 90-day survival. And what was found was that EVLP lung transplant was actually associated with significantly longer total ischemic times compared to non-EVLP lung transplant for both DCD and DBD recipients. However, there was no significant difference in 90-day survival for the full cohort, demonstrating that EVLP may be a valuable strategy to address the donor organ shortage and support efforts to further understand the utility for marginal lung donors, which is promising given that here at Cincinnati Children's, we have become the only pediatric center to use EVLP, or at least one of the only that we are familiar with when it comes to lung transplant. So the next risk factor for CLAD I want to touch on are infections, as it has been previously described that bacterial, fungal, and viral infections are associated with the development of loss. So here I present on the use of letermovir or LTV for CMV prophylaxis in lung transplant. The purpose of this study presented by the pharmacy group at Northwestern was to evaluate the efficacy and safety of letermovir compared to valganciclovir for primary and secondary prophylaxis of CMV in lung transplant recipients. So primary outcomes looked at safety as it relates to leukopenia and neutropenia, while secondary outcomes looked at breakthrough CMV infection requiring treatment while on prophylaxis and post-prophylaxis CMV infection treatment. And as you can see here, adverse effects such as neutropenia and leukopenia were significantly shown to be reduced with letermovir compared to valganciclovir, but that efficacy between those agents did not significantly differ. And the last risk factor I would like to address today is rejection, specifically antibody-mediated rejection, as we all know how common and often treatment-resistant antibody-mediated rejection can be, specifically within a lung transplant recipient. So the group at Cedars-Sinai presented a pretty fascinating poster, and I was actually able to converse with them quite a bit, describing their use of daratumumab, which is a monoclonal antibody which targets CD38 directly on plasma cells. So this prevents further antibody generation. And while this agent is currently only FDA approved in cases of multiple myeloma, this group goes on to describe how it may have a role in treating antibody-mediated rejection refractory to our current targeted approaches, which I have highlighted in the figure below. So their utilization was described in a 35-year-old non-sensitized female with refractory antibody-mediated rejection with HLA-DQ4 and HLA-DQA1 following treatment with 3 days of pulse steroids, plasmapheresis, and 2 doses of IVIG with rituximab, and then subsequently followed by anti-thymocyte globulin. So this patient received daratumumab subcutaneously weekly for 8 weeks without any adverse events or types of infectious complications. So following completion, the authors concluded that the donor-specific antibodies resolved and remained undetectable, stating that daratumumab did show efficacy and safety in this patient who is refractory to other treatment modalities. And you can see the MFIs that they listed were actually, relatively low as we consider some of the more severe antibody-mediated rejection cases. But however, more research is needed with utilization of this agent. So while CLAD has a well-defined diagnosis and staging process, in addition to treatments targeting the risk factors to prevent CLAD development, once that diagnosis of CLAD has actually been made, treatment options, on the other hand, are extremely limited and are fraught with a good amount of limitations. So therefore, novel therapeutic approaches are necessary in the arena when it comes to CLAD diagnostics. And this brings us to the final portion of my presentation, which is the clinical case. So I was invited to present this case on ruxolitinib preventing pulmonary function decline due to CLAD-BOS in an adolescent lung transplant recipient. And I was invited to present this at the Early Career and Trainee Clinical Case Dilemma series as one of 4 finalists. So for any early career pharmacists on this call, I would actually highly encourage you all to apply for this session if able, as it was extremely rewarding, especially if you have a novel patient case that you would think is, worthy of presenting, because it did allow me to pair up with an expert senior discussant in the field of lung transplant. So I was fortunate enough to get Dr. Marie Budev, who is the medical director for lung transplant at the Cleveland Clinic. And she really did serve as a wonderful mentor who truly helped me dissect the intricacies of this case and point out things that, I really wasn't thinking of from a pharmacy standpoint. So before I proceed, I have nothing to disclose aside from discussing both off-label and investigational use of ruxolitinib throughout the presentation. So diving right into our patient case, so I am presenting a Caucasian male with history of Wiskott-Aldrich syndrome, or WAS. So briefly, for those of you unfamiliar of this disease state, it is a rare X-linked primary immunodeficiency resulting in inadequate bone marrow function. As a mainstay of treatment, our patient underwent a matched allogeneic unrelated donor bone marrow transplant during his infancy period. And just about 1 year later, his bone marrow transplant was complicated by lung GVHD and WHO group 3 pulmonary hypertension. And over time, progression of these disease states ultimately led to pulmonary function decline and subsequent bilateral sequential lung transplantation in 2018. At that time, the patient was 9 years old. So looking longitudinally at our patient case, so our patient's transplant was a negative crossmatch with CMV donor negative recipient positive serology. He was discharged on post-operative day 30 on a triple drug immunosuppression regimen, which is our standard per protocol, routine opportunistic infection prophylaxis, as well as azithromycin. So in the 2 years following his transplant, he had no episodes of rejection, and his 2 personal best FEV1s are shown. He did have 2 non-consequential viral infections in February of 2019. But as you can see, by the June 2021 time point, that spirometry did start to slowly decline from his 2 personal bests. However, in October of 2021, the first significant decline in FEV1 occurred with a drop in FEV1 to 65% of predicted, which essentially triggered a workup. So nasopharyngeal viral PCR was performed, which was positive for both rhinoenero and parainfluenza at the time. So aside from a mild cough, the patient was asymptomatic throughout. However, given the drop, we elected to perform a bronchoscopy and biopsy guided by CT imaging, which further revealed the parainfluenza 4, but declared that he was negative for C4D staining as well as acute cellular rejection. So no treatment was initiated in this patient at the time, but spirometry was repeated in December, demonstrating an even further decline in FEV1 down to 57% of predicted, at which time the diagnosis of CLAD-BOS was made. Respiratory PCR was still positive for rhinoenero, likely due to the prolonged viral shedding that we see in these immunocompromised patients. And after full multidisciplinary review, the decision was made to increase maintenance prednisone at that time. So as I alluded to on the previous slide, our diagnosis was supported by new onset air trapping, as you can see here on the high resolution CT imaging on expiratory view on the right panel, denoted by the arrows in comparison to his baseline, which was in June of 2019. So like I previously mentioned, that while CLAD really does have this extensive way to diagnose and stage the whole process, really, once you get that diagnosis, the treatment options are extremely limited, and the ones that we do have both variable efficacy and associated adverse effects. Some of the ones that are described in the literature include immunosuppression conversion, cytolytic therapy, extracorporeal photopheresis, fundoplication, and retransplantation. So while there's starting to be more ongoing studies in adults in CLADs, as I mentioned, really this is where our novel therapeutic approaches come into play. And as a result of this clinical need, our research team at Cincinnati Children's is looking at this in real time through the proteomics of BAL samples from patients to analyze what types of pathways are truly at play when it comes to patients with CLAD versus those without. And what was found is an upregulation in the JAK-STAT pathway, which is an involvement in patients with CLAD-BOS versus those without. So from a clinical standpoint, our question of interest then became, what medications do we have available to inhibit the JAK-STAT pathway that has shown to be upregulated in these patients who have CLAD? So that now brings our attention to ruxolitinib, which is a JAK1 and 2 inhibitor, FDA approved for both acute and chronic refractory GVHD, which is an indication of interest that we have here. So the FDA approved dosing for this indication is 10 milligrams orally twice a day. However, there is off-label dosing to support use in the younger pediatric population with subsequent dose adjustments for both end organ impairment as well as toxicities. As ruxolitinib is a non-specific agent and does elucidate many off-target effects, I specifically want to highlight here viral infections, given our patient's history prior to initiation of ruxolitinib, that he did have an extensive history of developing some chronic respiratory viruses. So here is a brief figure depicting the efficacy of ruxolitinib in both pediatric and adult BOS patients, but these patients are after hematopoietic stem cell transplant, which is illustrating either an attenuation or increase in FEV1 following ruxolitinib initiation. And of note here, 2 patients in this cohort, patients number 3 and patient number 4, are pediatric patients, while the remaining were adolescent and adult in age. So as a result of these cumulative findings, we initiated ruxolitinib in our patient at the end of December 2021 and completed a prednisone taper at that time, back to his maintenance dose. So this immunosuppression conversion was executed by replacing twice daily MMF with ruxolitinib, initiating posaconazole for aspergillus prophylaxis, and decreasing tacrolimus dose due to the azole interaction. This regimen was extrapolated from the REACH-2 study, which is a study that our bone marrow transplant team at the time was utilizing pretty heavily. And finally, we continued to closely monitor CBCs, spirometry, therapeutic drug monitoring, as well as donor-specific antibody development. So going back to our patient case, looking at lung function, starting from diagnosis and subsequent ruxolitinib initiation, you can see that FEV1 steadily increased despite more viral infections that this patient ended up contracting, but it never did return to the baseline value. However, we were able to kind of attenuate it without further decline and even have an uptrend. But like I said, once again, we weren't unable to return to baseline. So to summarize and conclude our findings, we want to emphasize here that clinical multidisciplinary care, in addition to translational research collaboration, has allowed us to offer more personalized medication approaches to treat CLAD-BOS in a patient-specific manner. But yet this is really only the beginning, and ongoing research is needed to further elucidate which patient populations would most benefit from ruxolitinib therapy and when to actually initiate treatment. But this patient actually gave us a start and a primer to start utilizing that more heavily if the situation allowed for it. So I'd like to personally thank the following individuals, specifically Drs. Hayes, Ziadi, and Buddha, for their wonderful mentorship and support throughout the case. So to wrap up my portion of the presentation and to pull everything together, I want to summarize here that CLAD is the major barrier to long-term survival following lung transplantation. And while it has an extensive diagnosis and staging process, the treatment options once that diagnosis is made are extremely limited. Therefore, identifying and managing risk factors are key drivers in preventing the diagnosis, but clinical research and all of that type of collaboration has really allowed us to offer more personalized and targeted medication approaches to treat CLAD-BOS. And I wanted to end here with a scenic picture of Prague, just to illustrate that we got to see some beautiful sights during our travel. So I would highly recommend a trip if that's on anyone's radar. So at this time, that concludes my presentation. Thank you all so much for listening, and I will gladly accept any questions at the end of the full presentation.
Thanks so much, Stephanie. Bear with us. Oh, looks like Brendan has his slides up, so we'll go ahead and turn it over to him.
All right, hello everyone. Let's switch gears now and we'll look over some updates in heart transplantation that came out of ISHLT 2024. Before we dive into the actual content, I did want to just note that I do not have any financial interests or relationships to disclose that are relevant to the content of this presentation. Now, taking a look at the major themes that I noted during this conference, you'll see that most of the content presented involved either the use of DCD donors, advancements in organ preservation technology, diagnostics for monitoring transplant rejection, such as utilization of donor-derived cell-free DNA or MMDX, as well as some updates in the area of infectious diseases and some interesting abstracts that came out on multi-organ transplant as well. So let's dive in and let's jump right to the diagnostics for transplant rejection. Unfortunately, we won't be able to get to these DCD donors or organ preservation technology today. So we'll start with a few abstracts that looked at the utilization of MMDX. For those of you that aren't familiar with MMDX, this specific test uses microassays to measure biopsy-based gene expression. And it actually looks at ensembles of what they developed are machine learning algorithms that they use to interpret these results and then compare each new biopsy to this large reference set of earlier biopsies that they've already accumulated. MMDX is able to assess for T-cell mediated rejection, antibody mediated rejection, as well as recent parenchymal injury and atrophy fibrosis. So this first study here comes to us from Columbia and Cornell, and their goal was to evaluate the clinical impact of MMDX in the heart transplantation population, specifically those with suspected rejection. So they analyzed these MMDX results that were paired with histological samples from November 2022 to August 2023 in heart patients that underwent a for-cause biopsy testing. Histological samples were considered to be positive if they were ISHLT greater than 1R1A and or PAMR greater than 0. A positive MMDX was then stratified into 5 groups: antibody-mediated rejection, T-cell mediated rejection, mixed rejection, parenchymal injury, and then borderline rejection. When we take a look at the results from this specific study, they included 168 samples from 123 patients. The median time from transplant to MMDX was 24 months. And then the endomyocardial biopsy was performed due to an elevated donor-derived cell-free DNA in 41% of these patients. The MMDX was then performed due to heart failure symptoms in 19% of these patients, and then new allograft dysfunction in 15% of these patients. Of note, I do want to point out that donor-specific antibodies were present in 57% of the cases included in this study. So when you take a look at the figure here in the bottom right corner, you'll note that 70 samples were positive by MMDX, whereas on histology, only 11% were positive. The concordance between the histology and the MMDX was determined to be 67%. Now, concordance between the donor-derived cell-free DNA and MMDX was 53%. And among these 54 samples with negative histology but positive MMDX, MMDX actually changed treatment in 28 cases, or 52% of cases. Specific AMR and TCMR rejection therapy, which wasn't specifically detailed, was initiated in 9 and 5 cases, respectively. And then augmentation of maintenance immunosuppression was explored in 14 cases as well. So these authors ended up concluding that MMDX actually increased the number of patients with a positive result compared to histology. And they noted that this actually led to initiation of targeted immunosuppressive treatment for management of either AMR or TCR. So the next abstract that we have here also comes out of Columbia and Cornell, and they were looking at this correlation between donor-derived cell-free DNA and this MMDX in heart transplant patients. So of the 96 samples with paired donor-derived cell-free DNA, histology, and MMDX, 50% actually showed concordance between these tests. And then of the 50% that did not show coordinates or were discordant cases, 98% were actually due to a positive donor-derived cell-free DNA levels in the setting of a negative MMDX result. When they assessed this, looking at the positive donor-derived cell-free DNA level using the MMDX as the gold standard, this actually demonstrated a sensitivity of 96.4% and a negative predictive value of 95.5%, which is demonstrated here in this figure, again to the right. There were no differences noted in baseline characteristics within this patient population, including a previous history of rejection or rates of positive DSAs at the time of biopsy between the two groups. Now, although AlloMap scores were similar between both groups, donor-derived cell-free DNA levels were actually higher in the concordant group as compared to the group with discordant. Patients with positive coordinates actually had similar rates of histological rejection as compared to those with discordants. But I should note that in this specific cohort, antibody-mediated rejection was frequently found within the group of the positive coordinates, so actually 70% of cases, while it was not seen in the negative AlloSure and positive MMDX group. These authors ended up, again, concluding that consideration of utilizing MMDX as a gold standard for monitoring in the setting of a donor-derived cell-free DNA level of what they considered to be positive of greater than 0.12%, demonstrated this remarkable sensitivity of 96.4% and negative predictive value of 95.5%. Now, what are the actual outcomes looking like when we take into consideration the utilization of patients who have a positive MMDX? This study here that comes to us from Cedars-Sinai, looking at biopsy negative but MMDX positive biopsies after heart transplant, assessed 6 heart transplant patients who had a normal biopsy, i.e. no rejection, but a positive MMDX for rejection. They also looked at 11 heart transplant patients who had a normal biopsy and a normal MMDX. Now, when we look at the characteristics of this specific patient population, all patients had an EF of greater than 50%. And these subsequent one-year outcomes that they looked at included things like survival, freedom from ACR and AMR, freedom from CAV, as well as freedom from cardiac dysfunction, which ranged in anything, which was mainly defined as a left ventricular ejection fraction of less than or equal to 40%. And then the last outcome that they looked at here was freedom from these non-fatal major adverse cardiac events, including things such as MI, new congestive heart failure, etc. This study found that patients with normal biopsy but positive MMDX actually developed significantly less subsequent one-year survival and one-year freedom from ACR, particularly if the MMDX was actually positive for acute cellular rejection. There were no differences between those two study groups when it came to those other outcomes such as left ventricular dysfunction, CAV, etc. These authors ended up concluding that MMDX may actually have clinical relevance as untreated rejection may have serious consequences, especially if somebody T-cell mediated. Of course, larger studies will need to be performed in order to confirm these findings, but it's an interesting result nonetheless. Now, I want to shift gears a little bit and move away from diagnostics and talk a little bit more about some interesting infectious diseases topics that were presented during this conference. So the first is a study from UC San Diego Health, and they were looking at prophylaxis of donor-derived Hep C infection in our cardiothoracic transplant recipients who were treated or received a short course of direct-acting antiviral therapy. So this retrospective cohort of heart and lung transplant recipients who received an organ from an HCV viremic donor, they were treated with a 7-day prophylactic course of Mavorite. And of note, their regimen consisted of the first dose of Mavorite given within like 4 to 8 hours prior to the transplant surgery, and was then continued for 6 days post-transplant. They monitored hep C viral loads on post-op day 6, which they deemed to represent end of treatment. And then they checked it again at 1, 4, 8, and 12 weeks following the completion of Mavorite to assess for sustained virologic response. Now, 11 patients were included, 5 heart, 4 lung, 1 heart, lung, and 1 heart kidney. The baseline characteristics for this cohort is presented here to the right. None of these patients actually had detectable HCV RNA at any time point during this study, and sustained virologic response at 12 weeks was achieved in all patients. Authors also note no deaths, readmissions for hepatic complications, graft losses, study drug discontinuation, or medicated-related adverse events in this cohort. It's interesting to see that there was 100% prevention of HCV transition in this cohort of cardiothoracic transplant patients, especially with them receiving this shorter course, 7 days of Mavorite initiated preoperatively. I'm looking forward to seeing what data comes out assessing long-term benefits, as well as data in larger cohorts. Keeping on the same track of using the shorter courses of these direct-acting antivirals, this abstract from the Ohio State University Wexner Medical Center did something similar. So they were instead looking at utilization of Epclusa in both heart and lung transplant recipients who received an organ from an hepatitis C NAT positive donor. They had 2 separate groups, one of which was received a short duration of treatment with Epclusa plus ezetimibe immediately before transplant, and that was continued daily for 14 doses after transplant. They were compared to a longer course treatment group, which received basically 4 weeks of Epclusa. They checked viral loads on post-op day 7, 10, 14, 21, 28, 56, 84, 112, and 140. And the primary endpoint that they were looking at was obviously the prevention of chronic hepatitis C infection, which they defined as a undetectable hep C PCR at 4 months post-transplant. Now, 21 patients received an organ from a NAT positive donor, 18 of which were hearts and 3 were lungs. 5 of these patients received the short course of the direct-acting antiviral and the hep C entry blocker, and then 7 of these patients actually had a positive NAT on post-op day 0, but all patients were negative by post-op day 7 and then remained negative throughout the duration of follow-up. Of note, there was 1 patient that did die of unrelated causes, and they were negative for persistent hep C viremia. These authors ended up concluding that a shorter duration of 14 doses of a direct-acting antiviral plus an entry blocker is a safe and effective approach at preventing persistent hep C viremia in heart and lung transplant recipients. But again, they do note that the benefits of this shorter duration of treatment does help with reducing overall pill burden and medication costs when implemented. So one last hep C related abstract that I want to talk about is looking at these outcomes of CAV in patients who received a NAT positive, an organ from a donor who was who had hep C viremia versus those who did not have hep C. So this single center retrospective study looked at heart transplant recipients who, again, either received an organ from a NAT positive or NAT negative donor, ranging anywhere in the timeline of January of 2015 to December of 2018. Donor-derived Hep C infection was treated in this cohort with a direct-acting antiviral, and then annual CAV surveillance was recorded with a maximal intimal thickness, or MIT, from the left anterior descending artery. IVUS outcomes were evaluated by median compared to the Kruskal-Wallis test, and then they evaluated it dichotomously with an MIT greater than or equal to 0.5 millimeters as opposed to less than 0.5 millimeters for a chi-square analysis. Patients were followed up, as you'll see here in this figure on the right, all the way up to 5 years. Of the 123 transplanted patients that were assessed, 21 patients received a NAT positive organ. They found that neither the proportion of individuals with an MIT greater than or equal to 0.5 millimeters, nor the median of MIT were actually different between the NAT negative and the NAT positive recipients over this 5-year surveillance period. Now, during the same period, 8.1% of deaths and 8.9% of PCIs that were experienced in the cohort were not different between NAT negative and NAT positive donors. These authors ended up concluding that CAV outcomes among NAT positive and NAT negative recipients of organs from NAT negative or NAT positive donors were not different in this intermediate follow-up period, and they looked to assess further long-term CAV outcomes in these cohorts. So as we kind of move on to what is our last group of, or our last theme for the presentation, looking at multi-organ transplant recipients. So this study came to us from Virginia Commonwealth University, and they looked at a cohort of 532 patients utilizing CHLT data from the UNOS registry between 1990 and 2023. And really, they were looking at donor, recipient and donor characteristics, as well as risk factors for mortality, as well as recipient and graft survival at 30 days, 1 year, and 5 years. They found that the most common indications for combined heart-liver transplantation were congenital heart disease and dilated cardiomyopathy. You'll see here the patient survival rates at 30 days, 1 and 5 years were 94, 85, and 77% respectively. And then combined heart-liver graft survival was 93, 85, and 77% respectively. Compared to the group with congenital heart disease, dilated and restrictive myopathies were actually associated with improved graft and overall survival. And a higher donor left ventricular ejection fraction was also associated with improved graft survival. These authors ended up concluding that obviously combined heart-liver transplants are being performed at an increasingly higher rate, as this figure to the right demonstrates. And of course, they note those differences in graft survival based on indication for transplant. So I think this is actually a nice segue for me to talk a little bit about the abstract that I presented during this conference. And what we were mainly looking at was the characterization of infectious prophylaxis and complications in simultaneous heart-liver transplant recipients. Now, the timeline of infection in the general transplant population has been well described. We know that there are 3 periods of infectious risk. Within the first month, we see more nosocomial infections and donor-derived infections. Then as we space out to those first 6 months post-transplant, we start to see those opportunistic infections that are associated with more intense immunosuppression. And then at that 6 month point and onward, that's when we start to see more community-acquired infections and less of the opportunistic infections, specifically as this intense immunosuppression kind of begins to dwindle. At the University of Chicago, all patients will receive intraoperative prophylaxis with broad-spectrum antimicrobials for 48 hours post-op. This will obviously be delayed if the patient comes out of the OR with an open chest or if they have a delayed abdominal closure. When it comes to PJP prophylaxis, all patients will stay on this for 1 year post-transplant. When it comes to the utilization of CMV prophylaxis, this depends on the patient's risk stratification. For moderate risk, they'll be on prophylaxis for 6 months because the high risk will stay on it for a year. And then for those that are low CMV risk, they'll stay on HSV prophylaxis for 3 months. We do utilize invasive fungal infection prophylaxis for 2 weeks post-transplant for a specific group of patients who meet our invasive fungal infections prophylaxis criteria that are listed here to the right. Our agent of choice is fluconazole, 400 milligrams daily for that 2 weeks. But if fluconazole is contraindicated, we'll utilize mycophenolate until patients are able to tolerate fluconazole. Following the completion of this IFI prophylaxis, we will transition our patients to thrush prophylaxis until the prednisone dose is less than 5 milligrams per day. And then lastly, when it comes to toxoprophylaxis, for our high-risk patients, they will stay on that for at least 1 year. Now, I do want to briefly discuss our immunosuppression regimens for our simultaneous heart liver transplant recipients as well. For induction, we either utilize basiliximab or no induction. However, this is case specific. And then for maintenance immunosuppression, we use a triple immunosuppressive regimen, including tacrolimus, mycophenolate, and a steroid taper to off after 4 to 9 months, depending on the patient. And then our tacrolimus goals can range typically 8 to 10 immediately post-transplant. And then they could be as low as 5 to 10 as early as 3 months post-transplant. Now, the purpose of our study was to, again, characterize the infectious prophylaxis that's utilized in this patient population, as well as the complications that they experience following transplantation. This was a retrospective single-center case series of patients that were transplanted between July of 2017 and June of 2022. We included adults who received a simultaneous heart liver transplant and excluded patients who experienced mortality prior to 1 year post-transplant or received an additional organ besides a simultaneous heart liver transplant. So taking a look at our results, these are the characteristics of our patients that were included. You'll see that the mean age was 53 years at time of transplant, and the most common indication for heart transplant within the cohort was a dilated cardiomyopathy of ischemic nature. When it comes to indication for liver transplant, the most common indication was either cardiac cirrhosis or this miscellaneous group of what is listed as other indications. When you look at the mean MELD score, it was 16 within our cohort, and most of our patients were listed as status 2. 11 of our patients received induction at time of transplant, and you'll note here the stratification of our patient CMV risk with 16 high and 16 moderate. And then lastly, we did not have any patients that were high toxic risk. And then 12 of our 14 patients included within the cohort met our invasive fungal infection criteria. As we move on and look at the actual infections that occurred within these 15 months post-transplant, I think a great place to start is with the bacterial infections. So you'll see early on within the first 4 weeks, this is when we're seeing more of, again, our nosocomial infections, pneumonias associated with being on a ventilator, bacteremias. But as we start to get farther and farther out, you'll note an increase in gastrointestinal infections. Specifically, this is when all of our patients were having episodes of, or most of our patients were having episodes of C. diff, as well as other miscellaneous intra-abdominal and bacteremia as well. If we take a look at the viral infections that our patients experience, you'll see that one patient actually received an organ from a NAT-positive donor and was treated with a direct-acting antiviral. Then 2 of our patients experienced reactivation of hepatitis C post-transplant, and they also received treatment. I want to direct your attention to the CMV infections as you start to see here. When we get towards the time period of when we would typically peel off our CMV prophylaxis, you'll see that this is when our patients developed infection. What I want to note is that 3 of the 6 high-risk patients developed infection, and then 2 of our 6 moderate risk developed infection. I'll talk a little bit about this more in the conclusion, but I think this was a result to pay close attention to. Now, lastly, let's take a look at the fungal infections. Remarkably, 3 patients within our cohort, 21%, actually were treated for aspergillus. 3 patients were treated for an intraabdominal fungal infection, and then 4 patients received thrust treatment. No patients received treatment for toxo, and then we had 1 patient that was empirically treated for PJP. Again, this timeline of aspergillus infection really lines up with what we see in larger cohort studies, such as like the Swiss cohort trial that looked at fungal infections in transplant recipients. So we start to see these complications closer to like 100 days closer to transplant, despite current guideline recommendations saying that if patients were to receive aspergillus prophylaxis for in the setting of liver transplant, for example, it would only be for the first 21 days or so. So our conclusion here is that these patients will develop a wide array of infections following heart-liver transplantation. We experience what we seem to be an unexpectedly high rate of bacterial CMV and aspergillus infection. And what I would really attribute the high CMV and aspergillus infections to is most likely too high levels of maintenance immunosuppression, specifically when it comes to CMV, or I should say especially, because we would typically expect our patients to be able to clear viremia as we pull off prophylaxis and kind of pull back on our maintenance immunosuppression as well. Following the results of this study, we are considering broadening the UChicago fungal prophylaxis to actually cover for invasive mold infections. And we also hope that consideration will be given to establishing guideline-directed prophylaxis for these multi-organ transplants, which is what is presented for those who are recipients of heart and lung transplant recipients. So that is it for the portion of content that I have for today. I will also open the floor up to questions at this time.
Thank you so much, Brendan and Stephanie, for that really great overview. As of now, I don't have any questions from the audience. So just a reminder, if you have any questions or want to discuss anything that was presented, go ahead and put it in the chat. I thought that was a really kind of good overview of a lot of the different stuff that was presented at the conference this year. I think you guys really kind of hammered in some of the stuff that was popular. Of course, I think expanding the donor pool and non-invasive surveillance seemed to be a really big theme this year, as you guys mentioned. And as always, kind of CLAD and AMR treatment as well. And then from the LVAD perspective, for those of us that take care of LVAD patients, this year there seemed to be a lot as a follow-up to the publication of the ARES study and some good pre-specified analysis from the ARES investigators regarding the importance of time and therapeutic range for our antithrombotic therapy. And so that seemed to also kind of be a popular topic. And I'm sure a lot of these themes will carry over into the meeting next year as I think, Brendan, a lot of the stuff you presented on kind of the correlation between MMDX and biopsies and cell-free DNA really just make things a little bit more confusing sometimes when we have so much data in this day and age. So I'm still not seeing any questions. So I think with that, I can give everyone 7 minutes back to their day. Thank you so much for joining. This will be uploaded to our YouTube page, and stay tuned for our next webinar of the year. Thanks again to our speakers, and everyone have a great day.